I think we go on to our next talk. We have next Dr. Rohit Saxena, who is a professor of ophthalmology, All India Institute of Medical Science, senior consultant, neuro-ophthalm, and member ARC North. And he is going to be delving on evaluation of optic disc edema in a bilateral situation. On to you, Dr. Rohit.
I guess I'm audible.
Yes.
So I'll be talking on bilateral disc edema and some definitions we start off with so that we know what we're talking about. So optic disc edema is true disc swelling due to any cause. Papilledema is true disc swelling caused by raised intracranial pressure, although we often interchangeably use these, but essentially if you use the word papilledema, you're kind of meaning that there is a raised intracranial pressure. And pseudopapilledema is an apparently swollen disc which is not due to axonal swelling or any fluid accumulation in the disc. So these are what we usually use when we are giving terminology. So if you have a disc edema, you have a patient with disc edema, we've talked about unilateral, bilateral. So you have bilateral, the most common causes being pseudopapilledema, papilledema, grade 4 hypertensive retinopathy, occasionally bilateral papillitis, and not so uncommon in our settings. Compressive optic neuropathies has been discussed, and others like uveitis, infiltrative, has also been mentioned in the discussions previously. The most important thing when you're looking at bilateral is that they require a systemic and a neurological workup to come to a diagnosis. On the other hand, if you have a unilateral disc edema, essentially meaning that the other eye is normal, well covered by Rashmin, so you can say whether it's hyperemic or pale. And of course, if the other eye is an optic atrophy, so essentially again, you're back to the thought that there may be a disorder that's bilateral but affecting asymmetrically, like you would have in compressive lesions that may be involving the chiasma, so one eye gets affected much before the other, or of course it could be unilateral abnormality like ischemic optic neuropathy or optic neuritis involving one eye first and then goes on to the other eye. So that's how I would tend to approach any disc edema. So first thing you suspect a bilateral disc edema, a papilledema possibly. So could it be a true or a false papilledema? The key features are that vision, of course, initially would be normal in both, but over time you'll see it deteriorate in papilledema, but in pseudopapilledema it remains normal. Pupillary reactions are again normal initially in both, but may be affected later on in papilledema. You have but the key features is a small cupless disc, the absence of any features of edema or any features suggestive that there was old edema. The vessels are normal and not obscured. The vessels may be abnormally branching, may appear to rise from the disc abnormally. You may have the presence of a lumpy, bumpy disc like a scallop disc. And of course, if you want to see, then on an OCT or an fluorescein angiography, you would not see disc edema. So this is how you would see some features here. There is true disc edema, the vessels are obscured, there are a lot of hemorrhages, exudates. On the other side, while the disc margins do not appear sharp and you do not think that there is a clear margin, but you can see that the vessels are normal, there's no obscuring, there are no hemorrhages, there are no exudates, cottonwool spots. So this is the initial look when you're looking at a true versus a pseudo disc edema. So this is exactly what a papilledema or a true disc edema would appear like. Now again, another case where you believe that there is some blurred margins bilaterally, it may be papilledema, but you look at all these hemorrhages and exudates, they appear to be very far removed from the disc. So some of them are overlapping, but a lot of these issues are away from the disc. So this is not purely primarily a disc pathology. This was a patient of grade 4 hypertensive retinopathy who presented it to us and was kind of diagnosed outside as raised ICT. So you have a patient of papilledema. The clinical features would be if there is a raised intracranial pressure, nausea, vomiting, headache. There may be associated nerve palsies, particularly 6th nerve palsy, which may be bilateral. There is usually no significant visual loss till chronic stage, except of course you may have an enlarged blind spot or a gradual constriction of the fields. So it is important to do a full field analysis or even a confrontation fields to get you an idea of how the fields are there. Also, they may have transient obscurations of vision, which they will comment upon or which are important, and it becomes an important signpost of raised intracranial pressure. You could have it early when there are just early blurred margins where the margins are not very clear or the vessels are just obscured or just there is a bit of hyperemia. Over time, it gets established where the margins become extremely difficult to identify. There are a lot of exudates and hemorrhages. It can go on to a chronic stage where the edema starts coming down, but you have signs of old edema. And finally, of course, atrophic, where you have secondary optic atrophy with a dirty white-looking disc, with a lot of features suggestive that there was some swelling of the optic nerve head in the past. Like I said, the fields could be just an enlarged blind spot or a peripheral field constriction. Usually a fluorescein angiography is not required, but when in early cases where you are suspicious, an OCT and or an FFA may help you. The key thing is the moment you suspect papilledema, you need to identify the cause. The most important thing to rule out is a space-occupying lesion. Of course, others could be meningitis, encephalitis, aqueductal stenosis, or obstructive hydrocephalus, and of course, an raised intracranial pressure because of an IIH. The key features to do is, of course, an MRI, a brain MRI, and an orbits with contrast to rule out space-occupying lesions, and of course, to confirm the distended optic nerve heads, which can be seen in an MRI orbits, and of course, to rule out any other cause. A lumbar puncture gets essential if there is an IIH to rule out infections. And if there is no other feature, then, of course, if there is a mass lesion, you need to refer to a neurosurgeon. The presence of infections, of course, again, a neurophysician. But if there is a possibility of a raised intracranial pressure, which is confirmed on a lumbar puncture, your treatment is with a neurologist, where you may require to give up to 2 to 4 grams of acetazolamide. So essentially, IIH may have even normal imaging and there may be nothing in the brain, although you may see some amount of distension on the optic nerve along the optic nerve sheath, along the optic nerves in an orbital MRI. And of course, the CSF will have nothing but raised pressures and everything else is normal. And other than the nerve palsy that may be there, there is no other neurological sign that the patient may actually complain of. And IIH becomes a diagnosis of exclusion. Recent weight gain is one of the most common causes. We've been seeing a fair amount of IIH patients recently, probably because of weight gain related in the lockdown, besides, of course, COVID causing a hypercoagulopathy, which may cause a venous sinus thrombosis presenting with a raised intracranial pressure. So in the recent times, one of the important causes is to always ask for history of COVID in these patients. And of course, there may be other secondary IIH related to systemic diseases, endocrine abnormalities, and medications, particularly oral contraceptives, which are, of course, unmonitored and the patient does not tell you about. So it's very important to ask a detailed history on these issues. They may present with headaches, transient visual obscurations, diplopia, and tinnitus. And as I said, neuroimaging becomes the key investigator.
You have 1 minute remaining.
CSF analysis. The management initially will always be medical, rule out the cause, weight loss, control blood pressure, anemia, CPAP for obstructive apnea, diuretics, and the sheet anchor for treatment is acetazolamide that you can give up to 2 to 4 grams a day. Adjuvants like topiramate may be helpful. And the options are surgical if the medical treatment does not control the IIH and the patient continues to lose fields. If patient has predominantly headache, an LP shunt or a VP shunt becomes a much better option because headaches don't get treated by an optic nerve sheath fenestration. Dr. Jyoti, of course, will talk about ONSF, but if the patient is losing fields without any other headache or major problems, then an ONSF to preserve the vision is very, very helpful. And of course, is something that is extremely beneficial to prevent vision loss, progressive vision loss. So thank you very much for the opportunity, Dr. Chitra.
Rohit, very basic questions for the postgraduates. What would you like to tell them about the features of splinter hemorrhages in papilledema?
Splinter hemorrhages would usually be associated with the disc edema. So if you have splinter hemorrhages, you're sure that it's true disc edema and not pseudo disc edema. And if you have splinter hemorrhages, very rarely they are associated with brucin. Very rarely they may be, but if there are multiple splinter hemorrhages, you're almost sure that you have. Of course, if it's present bilaterally, it is secondary to raised intracranial pressure. Of course, if it's unilateral, then you need to rule out the unilateral causes of splinter hemorrhages, which would also include early glaucoma.
And how would spontaneous venous pulsations help in diagnosing true disc edema?
So absence of spontaneous venous pulsations help us in a way that they tell us that there is raised pressure. However, the absence does not actually, it's not that they're not present is diagnostic. So it's not something that is helpful, but if they are present, then you virtually have ruled them out.
Chitra, just to add, if there are
Yes.
absence of induced pulsations, that is more significant for papilledema than the spontaneous ones.
And also, splinter hemorrhages within 2 disc diameters is more specific of papilledema.
Right. So they need to be continuous with the disc pathology. So like I showed in that photograph, if you have it, you have a clear normal looking retina in between the hemorrhage or an exudate and the normal looking disc, then you need to actually consider that cause may be something else. So it could be, an abnormality in a vessel in that region. So whether diabetes, hypertension, infiltration, infection, those are your differentials then.
Murli, you have any question to ask?
Yes, Dr. Rohit, you mentioned that acetazolamide is given in a dose of 2 to 4 grams a day. So this is quite a high dose. So anything that, because most of us have switched to taking over from the neurologist because neurologists usually give 50 milligram like that. And
yes.
Would you recommend any blood tests to be done for follow-up?
So on follow-up, yes, of course, before you start on a lower dose. That is definitely true. We don't start these high doses at the very beginning. But if the edema is very severe, then up to 2 grams is something we very usually go up to. But yes, on the first 2 weeks after you've started such high doses, you need a kidney function test to make sure that there is no. But also once you start escalating dose of acetazolamide, you need to do a KFT because there should not be abnormal KFT to start off with, which was missed in the early periods. So that is something, yes, you need to follow up. And of course, we add potassium syrups along with that, tell them to take adequate amount of potassium in the form of either the added supplement or your coconut water and others, so that you do not have that risk of reduced potassium that is a risk. And these patients, the other problems that they have are GI related problems, which are not so significant, so can be avoided. But 2 to 3 grams, depending upon the weight, is something which we routinely go up to before we start thinking that it is a failed medical intervention and plan for any other surgical modality.
Thank you very much.